Formalmente les doy la bienvenida nuevamente a este 32º foro anual de investigación y educación. A nombre del comité organizador y de Recinto de Ciencias Médicas, le damos la bienvenida al doctor Robert Kerr. Les voy a dar con la doctora Wanda Maldonado, decana de la Escuela de Farmacia, para que haga la presentación formal del doctor Robert Kerr. Doctora Maldonado.
Okay, I'll do this section in English just for the benefit of Dr. Kerr and Loretta, his wife, who are with us this afternoon. We are very pleased to have our guest speaker this afternoon. Dr. Robert Boss Kerr, as he likes to be called, serves the American Association of Colleges of Pharmacy as Vice President for Academic Affairs. Dr. Kerr provides creative leadership for development, implementation, and assessment of programs in leadership, faculty development, curriculum development, assessment, educational research, interprofessional education, the scholarship of teaching and learning, and evidence-based teaching. Dr. Kerr has held a number of leadership positions in academic pharmacy and pharmacy associations. These include Associate Dean for Academic Affairs at the Philadelphia College of Pharmacy, and a number of leadership positions at the University of Maryland School of Pharmacy, including Chair of the Department of Clinical Pharmacy, Director of Clinical Pharmacy Residencies, Vice Chair for Education in Pharmacy Practice, and Assistant Director of Hospital Pharmacy. He has served as President and Chairman of the Board for the American Association of Colleges of Pharmacy, and twice as Chair of the Section of Pharmacy Practice in the same association. He also was the first Chair of the Section of Clinical Pharmacy in the American Pharmacists Association. He led development of some of the nation's first service and education programs focusing on pharmacist-provided patient-centered care and formal pharmacotherapy consulting services. Dr. Kerr has received numerous awards, including the University of California, San Francisco 2011 Distinguished Alumnus Award, designation as a University of Maryland Dean's Distinguished Educator, a Certificate of Honor in the Outstanding Faculty category from the Maryland Commission on Higher Education, and the Maryland Society of Health System Pharmacists' highest award, the W. Arthur Purdom Award. He has received nearly $2 million in grant and contract support as a principal and co-principal investigator. His research interests include healthcare educational systems design, program and curriculum assessment, primary care, medication therapy management, interprofessional education, patient-centered care, and interprofessional team performance improvement. His personal interests include his wonderful family, regular exercise, and making music with his guitar and banjo. On a personal note, I have known Dr. Kerr since I was a pharmacy student, as he was our professor for several of the therapeutics and clinical practice content areas. Even as a department chair, I remember him spending a great deal of time in direct contact with us. We were and still are very fortunate to gain from his perspective on the clinical practice of pharmacy, the future direction of the pharmacy profession, and pharmacy education. Over the years, and spontaneously, he became a mentor, for which I am very grateful, as he's always available to offer some words of wisdom. And now, without any further ado, we officially welcome Dr. Kerr to our forum, our campus, and to Puerto Rico.
Thank you, Dean Maldonado. I've only called her that, I think, twice. Wanda is how I really talk with her most of the time. Can you hear me all right? All right, good. First of all, thank you for inviting me to spend some time with you this afternoon. It's very pleasant for me to see groups of healthcare students and professionals and educators moving into the next generation of education and care, particularly as it relates to working well together for the benefit of health in our communities. I think it's really important. So I'm going to talk with you today specifically about the role of pharmacy in team-based patient care and in interprofessional education. And as part of this, I'm going to introduce you to some of the programs that are happening nationally from the federal government and some regional programming that we're actually bringing here to Puerto Rico in May. So we want you all to, I will point out those parts of my talks to get you interested in what we're going to bring to the island in May. And as any good educator, I have to list my objectives for you. You want to look at those? I guess I should show them to you. I actually am going to cover these. I used to tell my students that if they knew the objectives, they would pass my exams. Every single test item I would write would be correlated back to a learning objective, and I would list the learning objectives at the beginning of every exam. And then on every test item say this relates to learning objective number, whatever it was. So I do pay attention to learning objectives, and I went over this slide a little too quick, obviously. But the core thing here is to talk about concepts of interprofessional education and interprofessional care and interprofessional teamwork, describe competencies in healthcare, particularly as they relate to interprofessional competencies, and try to contrast those to the individual professions' competencies. What are the roles of pharmacists as not only educators in an interprofessional environment, but also providers of care? And I'm a real believer that pharmacists should be direct providers of care with the individual patient and taking direct responsibility and accountability for the outcomes of the patients that they see. We're going to talk some about behaviors, professionalism behaviors, and also how that relates to behaviors in an interprofessional environment, because it is a little bit different, and how those behaviors impact on patient safety and on quality of care. And then finally, how health profession students can be integrated into the interprofessional care teams that deliver care. So we're going to be covering most of those items, and my dear wife Loretta reviewed my slides last night, and she said, that one's boring, take that one out. That one's boring, take that one out. And I don't think she knows this yet, but I put them back in this morning. So we'll see if I get in trouble for that. There's a few definitions I want to review for you, and these are generally internationally accepted definitions, so I think they're important. The World Health Organization has published these in 2010. So interprofessional collaborative practice is defined as when multiple health workers from different professional backgrounds work together with patients, families, carers, meaning providers of care, and communities to deliver the highest quality of care. So there are some assumptions being made in this definition. One is that people will work together, and two, it's for the benefit of patients and their families, and that it also will deliver high quality care. Some of those are known to us. We know that there's evidence, and some of those we don't know yet. And the only way to know is to do it and then study it. World Health Organization has defined interprofessional education as when students from two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. And it's important that it's two or more, and that you're learning about each other, from each other, and with each other. And that's, as I'll talk a little bit more later on, is not the same thing as putting all of the students in the same room together. You know, you could put students from the different professions in this lecture hall, and we could give them a lecture, and that doesn't meet the definition of interprofessional education. Teamwork. Interprofessional teamwork is levels of cooperation, coordination, and collaboration that characterize the relationships between professionals in delivering patient-centered care. And this is from a recent document on core competencies for interprofessional collaborative practice that was published in May of 2011 by the Interprofessional Education Collaborative, which is a collaborative of the six, what we would consider probably the six major health professions educations associations. And team-based care is when care is delivered by intentionally created, not randomly created, intentionally created, usually small work groups in healthcare environments who are recognized by others as well as by themselves as having an identity, a collective identity, and they have shared responsibility for a patient or for groups of patients. So there's some important characteristics of this. First is that they tend to be small work groups in clinics, in hospital settings, maybe just on a ward of a hospital, or in a small community, in a community health center. They tend to be recognized by others, not just themselves, but by others, as having some type of an identity that says they are a team that is delivering care. And they're usually providing care for either one patient or groups of patients, preferably for groups of patients, because that's where there's going to be more impact. And then competencies are integrated enactment of knowledge, skills, values, and attitudes. We call knowledge, skills, values, and attitudes combined an ability. So it's integrated enactment of abilities that define the domains of work of a particular health profession, be it pharmacy, medicine, nursing, dentistry, physical therapy, and it's applied in specific care contexts. So, for example, the American Society of Health Systems Pharmacists has a set of core competencies for pharmacists that practice in the context of health systems practice. I want to make sure that I didn't skip something. Good. Now, I thought I'd start off with a case, and there's no quiz. Okay, it's okay. I don't think there's a quiz unless Dr. Maldonado wants you to have a quiz, and then we'll put it together. So you're reviewing a case of a 42-year-old woman with type 2 diabetes, and the pharmacy student identifies a problem with the patient's therapy that she feels puts the patient at risk. The patient has a serum creatinine of 2.5, i.e. has reduced renal function, and has been prescribed metformin, who is, as you know, is a primary medicine used in the treatment of type 2 diabetes. However, it should not be prescribed in patients with reduced renal function. It puts the patient at significant risk for serious adverse drug events. So the pharmacy student brings this up because the metformin was prescribed by the nurse practitioner in the clinic. Later that day at the team meeting, the pharmacy student brings this up. And as you might expect, the nurse practitioner becomes defensive. And the medical student interrupts the entire conversation and says perhaps he and the medical resident should be the only ones making the drug therapy decisions. This really, as you know, happens. This is often the types of interactions that occur. So somebody wrote a prescription that was probably not appropriate. The person who picked up on it didn't communicate with the person who wrote the prescription, so the patient probably got the medication. And then the person who feels that they have both expertise and authority, i.e. the physician and the medical student, sort of interrupts the whole conversation and says, you guys shouldn't even be doing that. This is our responsibility. So when you're an interprofessional educator, we have to learn how to handle that type of interaction to improve it, to make it more functional. And in May, when we come back, we're going to have a whole discussion around this case. Another case, a 54-year-old man is a regular patient in your team practice, has type 2 diabetes, and presents for a follow-up. Initially being interviewed by a team with a nursing student and a pharmacy student. That's the pair interviewing the patient. During the interview, the patient complains of athlete's foot, and since athlete's foot is usually treated with non-prescription medications, the nursing student defers to the pharmacy student for treatment. That's not unusual. You might say, go talk to your pharmacist about buying something over the counter for your athlete's foot. Neither of these two students examines the patient's feet because they feel that that's the role of the physician who is not in the room. So again, how do we handle that? Do you know the #1 cause of patients' feet not being examined, diabetic patients' feet not being examined? It's because the person who is going to examine the feet walks into the examining room and the patient still has their shoes and socks on. That's the only reason. So even the barriers that we think are not real become real barriers to the delivery of proper care. So again, we will talk about this, and what you will see is there's some crossover skill development that needs to occur in interprofessional education. So professional competence is when each profession must achieve and practice at its own highest level of competence. But there are crossover competencies. And in this latter case of the man with athlete's foot and diabetes, the crossover competence is the ability to do the appropriate foot exam to prevent lower extremity amputation in diabetic patients. It's a specific exam. And anybody involved in the care of diabetes patients should know how to do that exam. That's a crossover competence. And interprofessional team competencies are related to these individual professions and to the crossovers, but they're still different because it relates to how does the team interact with each other. So it's really related to the final question. How do we deal with the interprofessional team's apparent inability in both these cases to make the right decisions or to do the correct thing for the individual patient? Now, incorporating students into an interprofessional care environment, does anyone here know which health professions have interprofessional education in their accreditation standards to get their degrees accredited? You guys just went through a self-study in pharmacy, so I know the pharmacy people know this. Pharmacy. That was a hint. Pharmacy has it in their accreditation standard. Does medicine? No. Does dentistry? No. Does public health? No. Is there any public health educators in the room? I hope I didn't misspeak. Nursing? Yes. Okay, nursing. They just put them in, actually, not that long ago. So what we see is there are inconsistencies in what is even accredited in healthcare education in terms of whether or not students must be involved in interprofessional activities and learn in an interprofessional environment from each other, about each other, etc. And unless it's required by an accrediting agency, there's a good chance it won't happen. And why is that? Because we all fall back on the importance of our own profession's competency. We have an obligation to make sure that our students graduate with the highest level of competence in our profession. All of us, no matter what our profession is. So these interprofessional competencies tend to be nice, but not necessarily done unless we're forced into it through accreditation purposes. So there are barriers to having multiple students in an interprofessional care environment. And some of this just really is practical stuff. Space. Inundating a patient with a crowd of people, all of them asking questions. A lack of confusion about who's making decisions, both by the care providers as well as by the patients. And there's other barriers as well, some of which, quite frankly, are just related to our own attitudes about other professions, and our own profession. So there are a lot of barriers to making this work and to bringing students into these environments. And then there are student performance assessment strategies that need to be used in an interprofessional environment that are different than what we would use if we just had pharmacy students with us or if we just had medical students with us, et cetera. And most of my career I've been involved with interprofessional education and interprofessional care environments, but when we got down to assessing student performance, each college had their own thing that they wanted to test and assess. So the interprofessional competencies are integrated abilities that define working across the professions with other healthcare workers and with patients and families and communities to improve health outcomes. And sometimes we forget that the patient is part of the team. And in fact, the patient is at the center of the team. And there's a program at Jefferson Medical School and Pharmacy School in Philadelphia where they have an interprofessional education program where the mentor of the students is the patient. And they follow the patient as a team for several years. And so they get to see the entire mix of what happens to that person and what happens to the families. The Interprofessional Education Collaborative, as I said, has recently produced a document on core competencies in interprofessional practice, and there are 4 core domains: values and ethics for interprofessional practice, what are the roles and responsibilities, interprofessional communications, and then the concepts of teams and teamwork. And then there are subsets under each of those domains that I won't get into. So to have effective interprofessional education, we want professions to learn with, from, and about each other. So in other words, it's more than just common learning. It's more than just bringing people into an auditorium and sitting them down. When I was a student, all of us took physiology from the same professor, medicine students, nursing students, pharmacy students, etc. We all took it from the same professor in the same room. But we weren't learning from and with and about each other. We were just listening to the lectures and then taking exams. That's not the same thing. We also need to respect the integrity and the contribution of each profession. And this becomes a respect issue, and we'll talk a little bit more about that in a moment. But whatever the differences in their status in the workplace, all are equal as learners. And it's very important for us to try to move away from the traditional concepts of status in the delivery of health care for effective interprofessional learning and performance. We want to enhance practice with professions. Each profession will gain a deeper understanding of not only its own practice, but how it can be complemented by others and how to help reinforce that of others. And interestingly, studies have shown that there's an increase in satisfaction, in professional satisfaction, when you learn in an interprofessional environment and practice in an interprofessional environment. It tends to cultivate this sense of mutual support, and that tends to reduce occupational stresses, and it tends to set some limits on the demands that are made by one profession on another profession, and people start actually respecting each other more and don't get upset with each other so much. There's less conflict because they understand what's going on. There's a process called responsibility charting where one of the key elements is maybe only one person has responsibility for a task, but others have to be informed in advance of the performance of the task, and others have to be supportive of it. We did a little activity with nurse practitioners, medical residents, and pharmacy residents where we gave them several cases of things that had gone wrong. It was in a hospital setting. Serious things had gone wrong. And we asked them to go through and define all the tasks and who was responsible and who had the authority over those tasks. And as you might expect, the physicians felt they had all the authority and all the responsibility. The nurses felt they had all the responsibility. The pharmacists felt they had no authority and no responsibility. You know, that bothered me. But then we mixed them up. And we did some learning about each other's profession, what they all did in the hospital, what they really did in the hospital, what their responsibilities were. And then we said, now go through this again, same cases. And what we discovered is for different tasks, sometimes the pharmacist had the authority, and the nurse had the responsibility, and the physician was supposed to be the support person. Other times, the nurse had the authority, and the physician had the responsibility, and the pharmacist had to be informed in advance of it. And so what they ended up with is this matrix of responsibilities and authorities and who's informed and who's being supported, and it got across to them the idea that in reality we're all in this together, and we can't just start pointing fingers at people when something goes wrong. In 2009, a publication from McGraw-Hill pointed out that coordination on high-performing healthcare teams involves shared knowledge, shared goals, mutual respect, and it functioned across functional goals. But the quality of the relationships was a determinant of the effectiveness of the communications. So even if you provide timely and accurate information, it might not be heard. It might not be heard or acted on if the recipient of the information doesn't respect you. So if I might, I'll give you an example. Why not? I'll give you an example. Early in my career, I was on rounds with the chief of medicine at the University of Maryland, who was an internationally respected infectious disease specialist. And I, at the time, was very young. I won't tell you how old I was. I was very young. And he was an expert in tuberculosis treatment. And he had told the resident to write orders for a tuberculosis regimen on this little old man. I mean, little. And when we were on rounds, I said, Dr. Woodward, and he says, he always did this. Yes, Kerr. And I said, Dr. Woodward, I think you might have a problem with the dosing of this particular antibiotic in this patient. Why is that, Kerr? Well, I think he would get, and I went through this whole thing of the kind of damage he would get, and it ended up being 8th nerve damage, for those of you who just took neurophysiology, 8th nerve damage, and which causes hearing loss and also coordination loss. So he says, you really think so? Kerr. And we walked into the patient's room, and Dr. Woodward walked up to the patient and said, Mr. Smith, how are you feeling today? And Mr. Smith said, huh? Real. That really happened. Then we stood Mr. Smith up, and he fell. He couldn't coordinate himself. He was clearly toxic from his medication. So we walked out of the patient's room. Guess you were right, Kerr. From that point forward, Dr. Woodward had me writing the dosing of all his antibiotics because he now respected me. And at that point in time, he was the grand old man, and I was just this young nothing pharmacist going on rounds with him. So now we had a collegial relationship instead of a status relationship, and that was important. Behavior. Professionalism expectations in an interprofessional environment are a little different than a uni-professional environment. Interprofessional professionalism has been defined as consistent demonstration of core values that are evidenced by professionals that work together, aspiring to and wisely applying principles of altruism, excellence, caring, ethics, respect, communications, and accountability to achieve optimal health and wellness outcomes in individuals and communities. It's a lot of words. The bottom line is respect, altruism, excellence, caring, ethics. All those things are interprofessional behaviors that are commonly labeled as professionalism. And what we find, at least in pharmacy education, particularly in the experiential environment, there tends to be some concerns about the professional behaviors of some of our students. And that's unfortunate, but it's real. And occasionally we would get phone calls from a preceptor, can you please take this student out of my environment? And I said, well, I would prefer not to do that. Let's talk about what the problem is. And then we would work through the problem, and we'd talk to the student and talk to the preceptor and work it out and get them all on the same page. The answer isn't just to remove somebody from an environment. The answer is to improve the behaviors. HRSA's Patient Safety and Clinical Pharmacy Collaborative is a major effort nationally which is aimed at saving and enhancing thousands of lives, literally, and there's data to support this, but by achieving health outcomes and eliminating adverse drug events. And they do this by increasing clinical pharmacy services for the patients that are served in these centers of care that the collaborative is involved in. The collaborative was started in the summer of 2008, and there are currently over 110 teams over 300 partnering organizations in more than 40 states. And the goal is to have this process now in over 3,000 communities nationwide. The focus up to now has been on what is called the safety net, medical safety net, the underserved populations that normally would not be able to access care or afford care. And with healthcare reform, some of that is hopefully going to change, depending upon what the Supreme Court does in the next day or two. But the point here is that we are now trying to move this effort beyond the safety net, because the model will work in any interprofessional care environment. So if we're going to focus on what is now called the medical home or the healthcare home, where the patient is at the center and the other health professions are working for the good of the patient as opposed to their own good, and that's what happens a lot of times, we find that care improves, and we find that adverse events are dramatically reduced. And I'm going to spend a little bit of time talking about the work of the collaborative this afternoon. So there's a healthcare gap. There are barriers to care delivery. Access to information there's a barrier to access to information both for providers of care and for patients. Now, what is interesting to me is I would be sitting in my examining room and a patient would walk in and say, Dr. Kerr, I just pulled all this stuff off the internet, and according to the internet, the medicines you're giving me are going to kill me or something like that. And and then I'd have to talk about that. But patients have access to a lot of unfiltered information, and we need to be able to help them with that. There's a barrier to expertise availability and a lack of coordination of care. There's barriers to receipt of care, access to services, access to medications. There's a health literacy issue. People don't understand health and their health status. To you, it might be second nature. You know the words, you know the definitions, you know the vocabulary. But to the everyday person, they don't know that stuff. And it's very difficult. And then there's lifestyle issues that impact on barriers to receipt of care. And some of that, quite frankly, is cultural. If you come from a family or a culture where you eat a certain way, it's very hard to change that if it would help the person's health. I came from a family that did a lot of high-fat meat. You know, glad to meet you. Lots of meat. And my dad died of a heart attack at age 60. My mother died. Oh, the other thing they did was they smoked. Everybody smoked. You know, my dad was 4 packs a day. My mom was 3 packs a day. My mom died of emphysema at age 65. So the point here is that if folks have certain lifestyles, that's going to be a barrier to care. And there's an impact on quality. 47% of chronic conditions appear to be unsatisfactorily addressed. There are 22% of patients have multiple conditions, and 50% of patients with multiple conditions or chronic conditions, only 50% have satisfactory levels of disease control. And you notice that this is a disease-oriented concept, not a health-oriented concept, and yet we call it health care. It's really disease care. And I just came back from a major university where they wanted me to redesign their curriculum around the most common diseases in their community. I said, okay, so where does women's health fit in your curriculum? Last time I checked, that wasn't a disease. Last time I checked, pregnancy wasn't a disease, you know, and yet it wasn't really addressed very well in their curriculum because they were focusing on disease states instead of people. And there's an impact on safety. 1.5 million people are injured annually by medications. Documented fact. 25% of ambulatory patients report experiencing an adverse drug event. When I was a patient in the hospital about to undergo emergency hip surgery because I had shattered my hip, my wife and I picked up, about 7 medication errors in my 48 hours of stay in the hospital. And we're pharmacists. What about the average person, you know? So, 80% of medical errors are really systems driven. They're not because somebody's stupid or because they don't know what they're supposed to do. It's really systems driven. So what does a typical medication use system look like? Wanda, wave to me when I'm starting to run out of time. She just waved at me. Oh, my gosh. Keep going. Well, we have to have effective prescribing, right? We all say, there's a problem with people not effectively prescribing. If they would just prescribe correctly, everything would be just fine. And then there's sample room oversight. You know what I mean by that? It's particularly noticeable in family medicine clinics where the family medical residents are taught how to deal with samples. And there's a whole new system now that has to be used for sample management. And that the med reps have to report back. They have to keep track of all that. Somebody's got to pay attention to that. You know who usually pays attention to it? The salesperson or the secretary. It's not a health professional usually. Do we have population-wide outcomes assessments? For some things we do, like we know for hypertension what the population-wide data looks like, and it doesn't look very good and hasn't looked very good my entire career. It's gotten better, but it still doesn't look really good. Diabetes, we're just starting to get population-wide data. How about arthritis? You know, people complain about joint pain a lot. And the reason why new drugs that come out on the market for symptom release, primarily for osteoarthritis, really do good sales that capture market initially is because patients are dissatisfied with their treatment because they're always in pain. And so, do we have any population-wide outcomes assessment, for example, in degenerative joint disease? This one's unreadable, but it relates to the emergency department. That's why it's unreadable. Who's managing medication use in an emergency department? Patient education or patient counseling. Who really does that? Anybody? Oh, I thought you were doing it. No, I thought you were doing it. No, I thought you were doing it. So we're all going to do it 10 minutes before the patient leaves the hospital. We all gather around the patient and start educating them. How about prescriber education? Does that have any impact? We studied that at the University of Maryland, and we found that if we did focused prescriber education in a primary care clinic around specific things like the management of hypertension, that the proper drugs were prescribed and patients had better control of their blood pressure for about 2 months, and then went right back to baseline. So then we implemented a protocol. Wanda and I were just talking about protocol management. We implemented a protocol that got put on the front of every patient with hypertension's chart. You notice how you don't label people with their diseases. With every patient with hypertension chart, and we monitored whether or not the prescriber was adhering to the protocol. We went from 20% controlled to 80% controlled within 6 months, and it was sustained. So prescriber education is important, but you know what? Most prescribers are reasonably well-educated people. So that might not be it. Refill process. The pharmacists in the room and the pharmacy students in the room know that this is an issue. Patients don't pick up their medications when they order refills, or they just forget to get the refills, or worse yet, let's say I go to my physician and I have my medication for my, pick a disease, for my osteoarthritis, gets changed, but the first prescription doesn't get stopped, and it still has refills left. So now I get notification from my pharmacist that I'm not getting my medicines refilled, and therefore, obviously, I'm not adherent to my medicine. And so should the pharmacist fill both those or not? Are they supposed to be taking both of them? Our VA in Baltimore started a refill clinic just because of this problem, to make sure that we had good processes for patients getting their new prescriptions written and for the medicines being refilled. Laboratory monitoring, medication reconciliation, that's a huge one for patients that come out of hospital and they go home and they have a medicine cabinet full of drugs. And then they go, uh-oh, what am I supposed to take now? So they take all of it, or they take none of it, or they take a little bit of this and a little bit of that. And patients get readmitted to hospital because of this lack of medication reconciliation. Access to medications, affordability, managing affordability, individual patient monitoring, benchmarks on payment for performance. We're going to start moving towards payments for performance now. Somebody better be paying attention to those benchmarks or we're not going to get paid. Who's coordinating this chaos? What we need is a medication use system in the medical home, so it all aligns and makes sense. But we still need some type of coordination. So we have to have some type of patient-centered medication use system. It has to be, remember I said 80% of the errors are systems-based. And when you can see all that chaos, how these boxes came up, and it really is like that, it's chaos. Somebody has to be managing that medication use system. It is very, very complex. So what we're trying to do with the collaborative is to integrate clinical pharmacy services onto healthcare teams. And what we're seeing is an improvement of health status. And we have populations of focus. So we know that we're focusing on high-need patients, high outcome need. And the adverse events are going down. Now, this isn't an exact graph. This was a hand-drawn graph. But the trends are what we're interested in. Now, how reliable is our care in this country? It's a function, really, of both system and culture. On the left side of this slide is autonomy. It's really what much of our healthcare is right now. Individuals have their own autonomy. It's a physician in their office with a blank sheet of paper. And the patient walks in, and the paper has to be filled, okay? And then a blank prescription pad, and the prescription has to be written. It's custom crafted, and each doctor, physician, dentist, pharmacist, whoever it is, does their individual thing, does individual orders, individual order fulfillment, whatever. If we try to improve that chaos to where there's some standardization in training and we try harder, if we just tried harder, it would get better. And each staff member still has his or her own way. The error rate is about 1 in 10. We know that. The airline industry, if they had an error rate of 1 in 10, we'd be falling out of the sky. If we standardize processes, habits, and patterns, and we have multidisciplinary rounds, not necessarily interprofessionally, but they all walk around together, the error rate's about 1 in 100. If we start to defer to others' expertise, tell me about this person's nutritional needs, dietitian. And we have a deference to a culture of safety. And examples of this are blood banking and approval for high-risk orders. There's an error rate of about 1 in 10,000. And then in highly reliable organizations, the error rate is extremely low, and examples of that are anesthesia and the airline industry. So the Institute of Medicine Crossing the Quality Chasm report in 22, which followed the Air to Human report in 2001, talked about these 6 major aims that all healthcare organizations should focus on: safety, safe, timely, efficient, effective, and equitable patient-centered care. The national quality priorities for healthcare reform are chronic disease coordination, reducing the overutilization of care, dealing with end-of-life care. Well over 70% of healthcare dollars are spent in the last 6 months of life. And and we don't manage end of life well in this country. And that's because it's a human being we're working with. You know, it's one thing to talk about this at a population level, but when it's your grandmother, it's much different. So we talk about population health issues and, of course, safety. So the collaborative says more of the same? Not. All of those elements should be involved in delivery of care. Nowhere does it say that we should continue doing what we have always done, or that we should work in silos without collaboration, or that we are keeping non-physicians out of direct patient care, nor does it say we're going to train health professionals in the same old way. That's not part of this new dynamic. None of those things are there, and yet a lot of what we do is still like that. There's an Institute for Healthcare Improvement. I would like, if you get a chance, to go to their website, www.hsi.org. It has a lot of good stuff on it. And they are pushing the simultaneous pursuit of three aims: improving the experience of care. Think about the last time you got health care, and what kind of an experience was it? Improving the health of populations. It's nice to have grandma feel better, but if we could get a lot of grandmas feeling better, it's even better. And we want to reduce the per capita cost of health care. This country spends more on health care than, I believe, any other country in the world. But our health outcomes in critical core areas are no better than what are called third world countries. We don't do very well in some key areas, and particularly in some pockets of this, what we're calling the safety net. In the Mississippi Delta, the health outcomes are atrocious, particularly in terms of diabetes and chronic kidney disease. And yet we know how to deal with those things. Why aren't they being done? So we spend a lot of money, but we don't necessarily get the associated incomes. Now, academic pharmacy, as a person who works in academic pharmacy, I have to put these slides in. Okay, I still have a little bit of time. We want to do some research to help us improve capacity, evaluate the real and expected impact on health and economic outcomes. We want to develop quality performance measures, advance the concept of evidence-based, team-based care, develop, identify, and refine and disseminate best practices, and develop evidence for impact of interprofessional education. That is a role for academics to do, to develop those researches, that research and that evidence. We also have to teach, i.e. learn, to use evidence-based teaching processes. Don't just do what I feel like doing in the classroom. And some of the students in the room maybe at times in their lives have experienced that. You know, the professor walks out of their office, does whatever they feel like doing, walks back into their office and waves. The idea here is to do evidence-based teaching. We want to evaluate interprofessional learning and teaching. Teach students to be aware of costs, no matter what their profession, and to implement effective cost containment and cost reduction strategies, and to integrate the concepts of disease prevention, health, and wellness, so we can start calling it well care instead of health care. And then we have to provide service, provide individual and population interventions. That's why we try to get faculty to practice in these community health centers, along with the collaborative providers of care. Participate in the governmental efforts aimed at improving healthcare delivery systems, and prepare the faculty and preceptors to be good role models for their students on quality improvement and cost avoidance. This slide was one of the ones that my wife told me to take out, so I'll skip it. But basically, it's the 3 T's of research. We have translational researches where we go from the basic biomedical science to doing studies on clinical efficacy. And then from there, we go to studies on clinical effectiveness. That is what, we know a drug works, but how effective is it really, more of a population base. And then we move into what's called T3 research, where we're actually looking at what's happening in the delivery of care. So what the Patient Safety and Clinical Pharmacy Services Collaborative is doing is this T3 work. It's not randomized, double-blind controlled data, but it's data that tells you that X% of your patients have a hemoglobin A1C of less than 7. And you go for the low-hanging fruit. You get all the patients that have hemoglobin A1Cs of over 10, and then you get them down from there. And it's dramatic. And the cost savings for every drop, 1% drop in hemoglobin A1C is dramatic. So we want to close this gap and develop better outcomes through interventions. The collaborative uses what are called plan, do, study, act cycles, where the providers will find a specific thing they want to work on, have a small number of patients, implement one thing, monitor how it worked, and then either continue that, broaden it, or step back. And a lot of times you get some improvement and then it drops down, then some more improvement, then it drops down, then some more improvement, then it drops down. Even if you do nothing, there's going to be status quo drift, where a little bit of improvement will occur. So what we're looking at is to get really high-level change by doing these small cycles of plan, then do something, then study it, and then act on changing it again. That's why they're called plan, do, study, act cycles. So we want to, essential components that can drive change in the improvement model that the PSPC uses, the collaborative uses, is to have consistent use of clinical guidelines, standing order sets, use allied health professionals at their highest level of work, not at their lowest level of work, standardized documentation, so it's not just a blank sheet of paper, and change practice in response to the performance data. There's some key attributes to this improvement model. It has to be patient-centered, interprofessional, cross-organizational, and the health home is at the center. Systematically address medication management, safety and risk, do these cycles of improvement, and what people will try to tell you is, I don't have time for all this. I have more to do right now. I just don't have the time. Well, this is not new work, but it's a much powerful way to do the work we do in a better way. So what we're really talking about is not adding. We're talking about doing what we currently do better. There are some medication management issues in primary care that I think are important for us to understand. 71% of physician office visits had at least one prescription listed on the patient record for that day of the visit. 32% of adverse events which lead to hospital admissions are attributed to medications. And drug interactions are an important issue for medication use at home because of all the stuff that's in the medicine cabinet that I talked about earlier. Only 33 to 50% of patients with chronic conditions will adhere completely to a prescribed medication regimen. That's not very good. 58% of the United States physicians state that their patients often have difficulty paying for medications and paying for care. And, and we also know that medications are one of the most effective and cost-effective forms of healthcare intervention when used correctly. You're better off being on lipid-lowering drugs than getting bypass surgery or getting stents. So pharmacists clearly can optimize therapy outcomes, directly monitor medication effectiveness by interacting directly with patients, knowing patient assessment data, being able to perform that, do the foot exams if necessary, do the spirometry tests in the office for asthmatic patients, etc. Promote safe use of medications through quality drug information and adverse drug reaction monitoring and reporting. Promote cost-effective medication use through things like formulary development and therapeutic substitution so that the pharmacist has the authority to substitute just as effective less expensive medication regimens. And use health information technology wisely. We can do so much. You know, there's an app for that, for everything. Pharmacy practice in the medical home model, or what most people are preferring to call the health home model. Comprehensive review of current prescribed and self-use medications, and systematic assessment of each medication, appropriateness, efficacy, safety, and adherence. Develop a personalized medication care plan. And the students that we taught at Maryland would just go crazy with the repetitive care plans we had them develop. And then I was in an alumnus golf tournament recently, and a Maryland alumnus came up and said, Dr. Kerr, now I know why you made us do that over and over and over again. I said, why is that? And he goes, because now I can do it like that, you know, and it's right every time. As a student, it would take him 2 hours to do that. Now he does it like that because he did it over and over and over and over again. You know how long it takes a medical student to do their first physical exam? About 4 or 5 hours. Then they have to repeat it when the attending physician comes around and says, you know, you missed that one. Look at the glands in his neck. So we want to deploy optimal teams that include clinical pharmacists to change what is now being done. Why does change fail in organizations? Complacency, lack of a good team to carry the challenge, poor visioning. When John Kennedy said in 1960, we're going to send somebody to the moon and return them to Earth safely, that was a vision that a lot of people thought was crazy. But by the end of that decade, that had been achieved. But without the vision, it wouldn't have been. Poorly communicated, and then you can have a great vision that gets poorly communicated. Kennedy did a good job with that. Obstacles are allowed to block the change. Instead of removing the obstacles, we just say, oh, we're not going to do the change. And often the wins are few and far between. That's why when you do these plan, do, study, act cycles, you have quick wins that you can then talk to people about instead of waiting for some 2 years from now. Mission accomplished gets declared too soon. Do you remember the aircraft carrier? George W. Bush, mission accomplished. We do that in healthcare. Mission accomplished. The issues get addressed, but the culture doesn't change. So it just keeps happening over and over again. So there's 8 steps to leading change. Create urgency. Establish your guiding team. Develop a vision and strategy. Communicate to get buy-in. Empower, broad-based action. Empowerment is really important. Generate these short-term wins. Don't let up. Be persistent. Make the change stick. That requires leadership commitment. Requires measurable improvement. You have to know what you're trying to achieve. If you're in a lab and you haven't got your measurements down pat, you're not going to know whether or not your experiment worked. Integrate the care delivery. Develop these safe medication use systems, and remember the patient is always at the center, always. So where's the leadership going to come from? The commitment and support has to come from the so-called positional leaders, what are called capital L leaders, people like Dean Maldonado. The energy and action comes from the non-positional leaders, the so-called small L leaders. These are the people that make it happen on the ground. You have to have both of those. When I stepped down as department chair at the University of Maryland, I had more people coming into my office asking for advice than they ever did when I was the department chair. I don't know what, maybe they weren't afraid of me anymore. I couldn't control their promotion and tenure anymore. That might have been it. So who is your guiding coalition? Who do you need on your team? You need a public advocate. The public has to be behind this. You need a strategizer. You can do something called that you can get your leadership style studied. And if you're a strategizer, you need to be on this team. I'm a strategizer, by the way. Score very high in strategy. You need a data cruncher. You need a salesperson. You need a consumer. Don't forget the person who is at the end of all this. You need a consumer on the team. And you need a taskmaster, somebody who will keep us on task. I need someone like that badly. Am I running over yet? And finally, this brings it all together. This is called the change package model that the HRSA's Patient Safety and Clinical Pharmacies Collaborative has put together. And each of these yellow boxes has elements of each of the slides that we talked about. But it's all integrated together for optimal health outcomes and safe patient care. So it's a system. 80% of the errors are systems driven. If we have a system that is integrated, that leverages expertise, and has all those team members on it, and we have short-term wins, and we have somebody crunching data, we don't just ignore it. When I started clinical pharmacy, I was like a salesperson. I said, what do you mean I have to collect data? Well, if I collected data early in my career, I probably could have retired 20 years ago. The point, because it would have all been done. The point is that we got to collect data. You can do all these wonderful things, and then when you go to the pearly gates, St. Peter says, well, you've done good things with asthmatics, Kerr. Where's the data? So remember the goal: documented, safe and effective patient care through effective health professions collaboration. That's your goal. Thank you for inviting me. This has been a wonderful experience for me. Thank you, Wanda.
Okay, we have time for questions.
If anyone would like to ask any questions, I'll do my best to answer. I'm a professor. I can answer any question. Doesn't mean the answer is what you want to hear. Yes, Wanda.
I know that AACP has compiled in a document examples of how pharmacy schools have inserted themselves in this type of interventions with the collaborative. Can you comment on a common theme in terms of what kinds of issues facilitate that participation, what types of challenges are common?
Yeah, I think the challenges refer back to our own sense of identity as a pharmacist. There's a tendency to be hesitant to get involved in an environment where you may lose your identity. Remember that table where as you move to a more effective team, you lose your identity a little bit. You're not autonomous anymore. And all the professions feel that way. So I think that's been a major barrier. The other part, quite frankly, is that there's a hesitancy to see these plan, do, study, act cycles as legitimate research. And so they say, well, that's not double-blind controlled, randomized, blah, blah, blah. But darn it, the patients are healthier, So, and we got the data to prove that. So I think we have to legitimize that kind of research, that T3 research. And schools of pharmacy, quite frankly, have to make the commitment to putting faculty in these environments and putting their students in these environments. I'm going to go back to the dark ages when we started clinical pharmacy in hospitals. There were no clinical pharmacists in hospitals. The schools had to place faculty on rounds, bring the students on the rounds, and the schools made the commitment. Now, when I was the chair at Maryland, we said we will make the commitment to putting faculty in these environments, but we have a plan, a data-driven plan, that will say over X amount of time, the practice site will pick up payment for that person, or at least a portion of the payment, so that we have to deal with the cost elements of the care, not just with placing people there for fun and games. We have to know that we're doing it well. So what we do know and pharmacy's in a great position for this. If we use the medications correctly, health improves and cost goes down. Every time it's been looked at, that happens. So the schools have to make the commitment and then have the data collection processes in place. The schools are the best to do that. But I've talked to a lot of schools that are hesitant to make that kind of leadership commitment. And part of that is because we have faculties that are under research and tenure pressures. And they want to make sure that the work they're doing is valued by their peers back at the college. And that becomes a problem. I was recently had a conversation with the faculty, practice faculty at West Virginia, where they were worried about that. And I said, well, then you have to use your practice as your research site, as your laboratory, and collect the data and make it good data and then publish it. So I think that's been, the barriers really relate to making the commitment from a leadership perspective. The money questions, because the schools have to make the financial commitment. They have to pay for the people. And then change what they're doing educationally to be willing to put students into these environments that are different than the environments they normally go in. Yes?
Sí, se puede utilizar los micrófonos.
Better make it possible. See, I'm starting to study Spanish. I'm not quite there.
Hi, I'm Dr. Rossi from HRSA. You know, we have in Puerto Rico 20 organizations that has been supported by HRSA, and they are health centers that provide primary care services and then preventive ambulatory services. We are glad to have a lot of students that rotate from pharmacy, but what would be your best advice for these students when they rotate through these clinics as being agents of change that integrate the clinical pharmacy services within the standard of care that we have here?
Yeah. That's a very good comment, because what we find is that when we put learners in these environments, the learners have to become agents of change. And but that's why I think it's important to have them partnered with a faculty person who is also on that same page of being an agent of change. And so we want the students to, I think, should participate in some of the planning processes for what happens in the service, in the community health center. And when I visited several of those in Pittsburgh, they had the students participating in the planning conferences for what was going to happen in the service and in the center. They would review all the cases in the morning, and the student could impact on that in the morning. But they need to be able to participate in some of the administrative processes for change, and then get involved in documenting. You know, really collect the data that HRSA can use and others. And as you know, what HRSA does is bring all that data together. And although it's not real clean data, but I think it's that one. But by looking, for example, populations of focus with type 2 diabetes, what we're able to show is a certain percentage of hemoglobin A1 change in each center. And then consolidating the data. And then it grows like this, and the impact is literally over hundreds of thousands of patients when you start consolidating data and then projecting what the data can look like if you do this in 3,000 communities. So, and I think the students need to participate in that, because that's what creates the change. So it's not what the students want to do is, you know, go see patients. That's what they're educated to do. But they need to participate in these other things, because that's what's going to create the change. And what is really neat, too, and you've probably seen the videos of the patients, and I had one, and I had it embedded in the slides, but I already have gone over. It brings you to tears, what these patients will say. I had one patient say that she felt like she was in prison from her lung disease, and her pharmacist taught her how to use her inhalers properly, and for the first time in her life, when she was in her mid-40s, she was out of prison. That kind of stuff is remarkable. And And to me, we have to have data, but we also have to have those stories. You know, we have to build stories, and that's where your salespeople come in. And did any of you see, I think it was on PBS, the clinical pharmacist that works in a team-based practice, and it was highlighted on a PBS segment. And it was remarkable. And everybody's saying, oh, man, that's so unique. And it isn't unique. It's happening all across the country. But why don't people know about it? We don't know about it because we're doing a bad job of data collection and sales and making sure people understand the cost data, you know. We can redo. I have told, you know, the pharma, the guys that make the real expensive drugs. I was at a meeting with them one time where they were really concerned about cross-border drug trade with Canada, all the drugs coming in from Canada through the internet. And they said, it was interesting, the Canadian health officials called them the skateboarders because it's these long-haired guys that have set up internet sites for drugs. And pharma threatened Canada with saying, well, you're not going to get our new blockbuster drugs if you keep allowing this cross-border drug trade. So I raised my hand, and I talked to the CEO of pharma, and I said, tell me one of those blockbuster drugs that makes a difference in the treatment of diabetes, in the treatment of hypertension, in the treat. You know, I can treat most people with high blood pressure with a drug that costs pennies a day. And I know I can. But we don't think like that. We always jump on the most expensive thing first. And so I think if we get students thinking population level, they can become better change agents. Did that answer a little bit, I hope? Anybody else? I'm starting to get a little restless in the room.
Answering to that question also that she posed, currently I'm a fourth-year student, and we are in advanced rotations. And I like this conference so much because when you talk about being agents of change, I also like to be, you know, as a student, like my opinion to be considered. And then I'm in a really exciting rotation right now, ambulatory care, with one doctor, Dr. Sacha Rivera from a faculty. And we have a system that is very, in this clinic, we have a system that it's old. We don't have electronic records. We have a paper record. And they're moving forward in having an electronic record. And she was working with us to see how we can do our notes. So our information that we put in the record is understood and considered by the primary care physician, by the nurses, and by everybody in the healthcare team. And it's been really, really exciting because she listens to our opinion.
Yeah.
She is there sitting with us, like we created, my companion is somewhere over here, right here, Janina. We have very good, exciting conversations because we have this format, and then we have to write our sub-notes, but it takes time to type it. Then we have to write it by hand after we've been corrected by the preceptor because she needs to check our work, obviously. But it's not effective. It's very inefficient because the time that you should spend learning other stuff and maybe creating databases to have that data being analyzed at the clinic, we spend writing by hand when we already type. And so she's been very willing and open to listen to us, but I think, like, I don't know what suggestion you also give to preceptors, because this is my opinion as a student. I am very happy with her because I know she has a way to do things, but she also is open to listen to us, to our opinion, and being part of the team and making that change. And I guess the people in charge of the clinics, the administrative personnel, and healthcare providers in general can use us also as agents of change and not just being evaluated and see where we failed.
That's great. great. You know, you're describing something where you're intimately involved in not only the care of the patient, but what's happening. And when I was in Pittsburgh, the director of the clinic there came around and said, I don't know what we could have done. I don't know how we did this before we had pharmacy students with us. And I believe that pharmacy students can be precepted by nurses and by physicians, and you know that's what interprofessionalism is supposed to be about. But what you just described is there's a triad a little bit. The schools, and I used to be in one of these schools that was really strict about telling preceptors what they should do with students. And then there's what the clinic wants done. So the school wants something done with the student, and the clinic wants something done, and then the preceptor wants their way. You know, I used to have a preceptor work for me, or actually a faculty person. There was the right way, the wrong way, and his way. You know? So I think what you're describing is where the student gets at the epicenter of that and has to know how to manage that potential conflict. The issue of electronic records, clear, and they're really, you know, what we can do now on, you know, the power of a tablet is remarkable. I was just at a Walgreens where they've changed their entire pharmacy system to be patient-centered, and it's all right there on a pad, and everybody knows exactly what's going on, including the patient. But but a lot of places just don't have that luxury, you know. It costs money to implement electronic health records, and it takes a lot of time and expertise. I was fortunate working at the VA, where they were one of the first places to have integrated electronic health records, and a veteran could come to me in Baltimore traveling through to Florida from Boston, and he'd stop in because he was having some problem, and I could call up his records and know exactly what happened with his last visit, what happened in the pharmacy, what counseling he got, the whole thing. And I think the power of that is strong, but when you go into a safety net environment where there isn't a lot of money, and you're trying to do the best you can, then you do it with paper and pencil if you have to. But Stephen Chen at the University of Southern California has developed standardized forms that really make it much more simple, and then the forms can be consolidated electronically later on if need be. But you shouldn't have to be. The only reason why you should be rewriting is because you had to improve it, not because of a system that's making you rewrite. The error rate in rewriting things is dramatic. That's why there used to be a lot of mistakes in hospitals, because nurses had to transcribe all the time. Does anybody here know what irbesartan is? Raise your hand if you know what oh my goodness. Wanda, I just did a pharmacology test. Thank you for your comments. But I'm going to talk about something else. It's an ARB inhibitor. It's an ARB. Okay, good. I was on one of those for my blood pressure, and I was in an accident. Yeah. Shattered my hip. I'm sorry. And that's a once-a-day medicine. And I was admitted to hospital with blood pressure of 60/10. I had lost a lot of blood. And the next day, post-operatively, the nurse comes around, takes my blood pressure, and it was 70/20. And she gave me the blood pressure antihypertensive medicine because it was on the record. The nurse wrote it down in the ER that I was taking that medicine. I didn't notice. I was kind of out of it on narcotics, so I didn't know what was going on. I just kept hitting the button for more narcotics. And that night, she came around, took my blood pressure again, and it's like 60/0. And she hands another dose to me of a medicine that's only supposed to be once a day to begin with. So I looked at it. Now I was awake a little bit, and I looked at it and I said, why are you giving me that? Because the doctor said so. Okay, what's my blood pressure? Okay, what is this medicine going to do to my blood pressure? It's a once-a-day medicine. Don't you know that? The doctor said. I said, okay, I'm not going to take it. I got labeled in the chart as an uncooperative patient. So record keeping, you know, the paper in hand record keeping, the error there was a handwritten transcription error. And so there's a problem with that, but you do the best you can with what you got. And I think the students that I've talked with that are in these environments say, this is what I've been educated to do, and I really want to do this. So you guys are going to be the next generation of doing it, I think. And you guys will get it done. We're over the hump now. Well, again, thank you for your time, and I hope I didn't go too long. Thank you.
Dr. Kerr, thank you again very much for being here and give this extraordinary presentation. We have a gift for you. This is from the Chancellor and the Dean for Academic Affairs, University of Puerto Rico Medical Science Campus, which says, in recognition of your outstanding contribution as speaker in the 32nd Medical Science Campus Research and Education Forum, today, March 28, 2012.
Thank you so much. Thank you.
Also, we have a second gift for you, which is a certificate. Says,
Where's the money? No.
Dr. Robert Kerr, in recognition for your outstanding participation as a keynote speaker in the plenary session hosted by the School of Pharmacy, today, March 28, 2012.
Thank you so much. Thank you.
A los invitados les digo gracias por asistir hoy a esta plenaria auspiciada por la Escuela de Farmacia. Les invito a que mañana asistan a las próximas sesiones de plenaria, etcétera, empezando desde las 8:30. Muchas gracias por asistir hoy.